This is Dr. Chris Robertson providing an overview of upper respiratory infection. This is inflammation of the upper respiratory passages, which is distinguished from the lower respiratory airway, and is due to infection of the mucosa, mostly caused by viruses. Keep in mind that 25% is going to be caused by bacteria. Be mindful that in older adults, this can be serious, particularly if superimposed with underlying respiratory diseases or if viral upper respiratory infection is complicated by bacterial superinfection. When it comes to the history and physical with these patients, you typically have symptoms that are mostly confined to the upper airway. So from a subjective standpoint, you see what patients will report, and from an objective perspective, you see what you will find on physical exam. When it comes to diagnostics, none are typically needed. If you're doing a rapid strep, you're doing it because you want to rule out group A strep if it is suspected. Obviously, the same with rapid flu testing, as well as mono testing with monospot. Typically, imaging is not routinely indicated. Antibiotics are not recommended with upper respiratory infection, again, unless there is a suspicion for bacterial etiology. When it comes to management, we're doing supportive care and managing symptoms. Typically, when patients present for upper respiratory infections, there are a number of over-the-counter things that they can be given. However, to manage their symptoms, there are things that you can prescribe to help with their symptoms. So you have over-the-counter nasal saline irrigation, and also recommending the humidifier, over-the-counter analgesics that they can take for different aches and pains, decongestants, antihistamines. There are some times when you have the option to prescribe an antihistamine. It's not necessarily that it's going to work better because it's prescription, but again, this is a way to kind of mediate not prescribing an antibiotic. Intranasal corticosteroids are over the counter. However, I typically tend to still give patients a prescription. One, insurance will still cover it, and oftentimes it is more cost effective for the patients to have it prescribed, and it does alleviate some of the nasal symptoms that accompany upper respiratory infection. Obviously, mouthwashes, gargles, as well as any lozenges for sore throat. Again, in older adults, you need to consider various cold medications and their potential adverse effect when it comes to items that you would recommend. With regards to follow-up and referral, patient education for upper respiratory, it's important to let them know that it does resolve spontaneously without intervention. Encourage fluids, hydration, and rest. Make sure that they understand the difference between viral and bacterial infections, and when it's appropriate to use antibiotics, making sure that you are also a good antibiotic steward. Obviously, good hand hygiene, letting them understand that typical duration is 5 to 7 days, but can be up to 2 weeks. Cough, again, may be another persistent symptom, so it's very appropriate to prescribe medications to help with cough. And obviously, if your patient is a smoker, you want to have conversation around smoking cessation and their readiness to quit. Follow-up and referrals, typically not indicated. However, you will want to have the patient follow up if they have prolonged fever, difficulty breathing, or if there is concern for any type of secondary complications, which may require or which would require treatment with an antibiotic, including otitis media, sinusitis, bronchitis, or pneumonia. And this concludes the overview of upper respiratory infection.